Let's go ahead and get started with the next session. It's a great pleasure to introduce Dr. Fontana, Greg Fontana, who will be moderating the session. Greg is the National Medical Director for Cardiovascular Research for HCA and is based out in California, Los Robles, just outside Los Angeles, correct?
Yes.
And Greg is a leading light in the field of TAVR and many other things. He's been one of the innovators. Was the past president of ISMIX last year, and we're delighted to have him back this year. Thanks, Greg.
Thank you, Mahesh. Always a pleasure to come visit my friends in Houston, and really a great meeting. Welcome to everybody. This next session, we're going to focus on the aortic valve, both transcatheter and minimally invasive surgical, and we're going to have three talks. First on TAVR by Mike Reardon. I'll come back with mini sternotomy for AVR, and then Mark Rule on mini thoracotomy, and hopefully have a little bit of time for discussion before the lunch and the lecture by Dr. Bonatti. First up, Mike Reardon. I'm sure all of you know he's become clearly a household name around the world now in TAVR, and has had an incredibly great experience across many devices in the transcatheter space, both as a site and a national PI. And most recently, really a spectacular presentation at ACC on intermediate risk from the TAVI trial. So it wasn't that long ago, Mike. It seemed like wasn't that hard to put together a talk on TAVR in 30 minutes. And now I know we all sit down and think, oh my God, how do I distill all this incredible experience, which, by the way, the first valve was done 15 years ago this month in France. So in 15 years, the incredible experience we've had and a number of trials. So it's your challenge, and 30 minutes or less to distill that down. Transcatheter aortic valve replacement, Dr. Reardon.
Well, thank you, Greg, and thank you for the kind introduction. Greg is not only a world-class surgeon and a good friend, but he has impeccable taste in food and wine. So if you ever get to have dinner with Greg, don't pass that up. So, when I originally put together this talk, I did like I always did. I put together a data-heavy talk, and Mahesh came to me and said, no, this isn't a data-heavy session. This is a kind of, let's talk about how we do it. I do have a lot of ties to a number of the valves out there, but this is not going to be a commercially driven trial. But I do want to talk a little bit about why do we do TAVR? Because you need to have some sense of the data out there if you're going to do this, if you're going to talk to your cardiologist, or if you're going to do it yourself. So these are the two extreme risk trials that have been done. The partner B trial, which was the inoperable randomized against medical therapy in the upper arm, and what you saw was a 20% survival advantage to TAVR at 1 year, and that extended all the way out to 5 years. In fact, there was only one medical patient alive at 5 years who had not had an AVR or TAVR, and that individual patient actually had 3 BAVs to get him there. So for these old patients, having symptomatic severe stenosis is not a good thing. And then below, that's the core valve extreme risk trial. By the time we had designed this trial to look just like PARTNER, and we were going to randomize against medical therapy, but by the time PARTNER came out, it was clear it was unethical to randomize against medical therapy. So we used performance goals, which was a 95th percent lower survival level from the PARTNER A trial at 1 and 2 years, and clearly easily beat that. So that led to these trials being approved, and they now are 1A in the old guidelines, and they are 1A in the new guidelines. And then came the high-risk trials. In the upper left, you see the PARTNER A trial. This is actually the 5-year data that was presented by Michael Mack. And what we saw was equivalent survival all the way out to 5 years. And then below, you see the high-risk trial that was done for core valve. And interestingly, at 1 year, there was actually superior survival. Superior survival. Now, this was a little controversial because the statistical method we used did a non-inferiority test first, and hierarchical went to a superiority test, and so it was superior by a one-tailed alpha, and everybody got all upset about that. And then at 2 years I presented it was still superior by two-tailed alpha, and then by 3 years Michael D presented it was no longer superior statistically, but it still had a delta of 6.2. So these tests are now done. And in the new guidelines, TAVR for high risk is now a 1A recommendation. It equals that of surgery. So again, as Greg said, 15 years ago is the first time we did this. Now they're 1A for extreme risk, 1A for high risk. Then we go to the intermediate risk. In the upper left, you see PARTNER 2A. The PARTNER 2A was presented by Craig Smith and published by Marty Leon. And what you saw was that they met their non-inferiority powered primary endpoint. So non-inferior. They did a subgroup post-hoc analysis that was planned into it of transfemorals, and if you looked at the as treated, then it actually reached superiority at 0.04. The intent to treat, which is what they were looking at statistically, was 0.05, but any way you look at it, it's really strong data. Now we've moved down to intermediate risk. The mean STS in this was about 5.8. You go down to TAVR, and it met its non-inferiority primary endpoint of all-cause mortality or disabling stroke at 24 months, and had mortality that was exactly the same. A mean STS of about 4.5, a surgical observed to expected mortality of 0.31. Really good surgery, and yet TAVR kept up with it. So now, if you looked at the new guidelines, which came out just before the ACC, TAVR is now was a 2A in the new guidelines. But if you go forward and you look at what we have right now, so for prohibitive risk, TAVR is class 1A, high risk, TAVR 1A, and intermediate risk, right now it's a 2A. With TAVR data, next time they meet, it'll be a 1A. The guidelines need 2 studies to go to a 1A, and that leaves us with low risk. And there are low-risk randomized trials going on. There's the Partner 3 trial, and there's the Medtronic Evolute low-risk trial. They're fairly similar. There's an age limit in the Partner trial of 65. There is no age limit in CoreValve, but we really don't see many we didn't put a lower age on it, but we're not seeing a lot of young people because they either have bicuspid valves or they're really not appropriate for this. And low risk is defined as a operative mortality by the heart team of less than 3%. Now, why is that important? Well, high risk was about 6.2% of what we were doing as surgeons. Intermediate risk was about 14% of what we were doing as surgeons. Low risk is about 80%. Now, every surgeon I talk to, oh my God, all my cases are going to go away. They're not all going to go away. Not everybody's going to be appropriate for TAVR. If low risk turns out to be non-inferior, and it will, I can show you by looking at instantaneous hazard risk of death and how they're trending, it will be non-inferior because they're both so good that this will now be an option. They won't all go to TAVR. They shouldn't all go to TAVR, but some of them will. And if you want to win as a surgeon, you need to be able to do both of these. Now, why else? Well, this is our valve clinic. We got passed over for Partner. We got passed over because we really weren't a very organized team, and people were really fussing at us about, well, we're not going to work with you because this group is fighting with that group. In fact, they passed over all of Houston. Well, when that happened, we said, listen, we're going to get organized. We're going to have a valve team. We're going to build a valve clinic. And I haven't followed this all the way out, but last year we saw 252 new patients in valve clinic. We saw over 1,000 total new patients. And we now see about 120 patients a month in our valve clinic. This is a brand new clinic, apart from all our other clinics. So if this was a business, you could arbitrage this through the roof. I don't know if I'm pointing at these things. So this was our TAVR volume. And again, it doesn't go all the way out, but last year we did 296, so you can see the trend continues. And the red is our aortic valve volume. So last year we did 296 TAVRs. We did 312 surgical valves. So if you look at our isolated aortic valve procedure, not roots or anything else, it's now over 600, just over 600. And that's growing from the year before when we did 231 aortic valves. So again, this is really big for your programs. That's why surgeons need to be involved in this, because if you're not involved, you're going to see this happen. So let's move a little bit to the how we do this, because that's what this is about, is how do we do these things. So I think first we really need to recognize there are differences between surgeons and cardiologists, and we need to kind of understand those differences if we're going to understand each other. You know, surgeons see the world in color. We use these imaging things that our parents gave us, our eyes, and cardiologists tend to see it in black and white on panels. Now, the good news is surgeons are slowly moving that way because we're seeing more and more of that. If I said I sawed something, you all think I cut it with a saw. If I said I sawed something, the cardiologists think I'm using the past participle of the verb to see and I must be a hillbilly. You know, it's just a little bit different. When I say wire to one of you guys, you think about a wire for a chest, but you know, the cardiologists think about a different kind of wire. And of course, if you say lead to a surgeon, I'm thinking about something different than a cardiologist. So we have to realize there are some differences that we need. And as surgeons, one of the hardest things I see, particularly for mature surgeons, that's I like to call myself mature rather than old granddad, is that, you know, we're used to being in command of our operating room and knowing every piece of equipment and what its name is and often the history of that piece of equipment and how it's used. And now all of a sudden we're going to be thrown into a place where we don't know the language, we don't know what's being used, and there's certain things that if you learn the basics, you're going to be okay. And the basics are access, sheaths, wires, catheters, and techniques. and they're not hard to learn. If I can learn them as a 64-year-old guy, you guys can learn this. So access, so this is just an interesting, somebody asked about transapical earlier. The blue line is transfemoral TAVRs in the US TVT registry. The red is transapical TAVRs. The green is transaortic, and the purple is other. Well, look what's happened to transapical. They've almost gone away. Direct aortic's almost gone away. I did a direct aortic this week. It's the first direct aortic I've done in a year and a half. In a year and a half. And I helped Medtronic develop the technique for direct aortic. I thought it was a really cool thing. It was going to be a big deal. We are now over 95% transfemoral, and most mature programs are. So you need to know femoral access. Now what we do is I use ultrasound and micropuncture technique to do this. When I first started, it wasn't my surgeons that were pushing against the ultrasound. It was actually my cardiologist. My older cardiologist said, you don't need ultrasound, you stick the artery. And I finally had to convince him, Neil, if you can see it, why wouldn't you see it? And if they have the ultrasound there every time and you get used to using it, you'll be amazed how easy it is. You can see the calcium, you can see the bifurcation, you know exactly where you're going to stick it. My anesthesiologist will not stick a vessel without ultrasound. Why? Because it's the standard of care. You should not stick vessels without ultrasound. You should know what you're sticking. And, well, that's interesting. Did I do something, or did y'all do that? Or has my time run out? Can y'all bring the slides back up? So we use 2 ProGlides. ProGlides are a little Prolene stitch with a little slip knot in it. You put it in there. I have a little video at the end that'll show you a little bit more about how to use it. But we do everything percutaneously. Unless there's some specific reason we would never cut down. There's some really cool large vessel closures devices coming down, like Manta, which is a little bioabsorbable shield that pulls up against there that I think works a little bit better than ProGlides, and it's being tested right now. Sheaths. You know, everybody gets confused about sheaths because somebody said, do you want the Gore sheath? Do you want the dry? Do you want the Cook sheath? You know, do you want the E sheath? Do you want this sheath, that sheath? Listen, sheaths are done by size, Frenches. The French size of the sheath is not the outer diameter, it's what the catheter will go through it. That you need to know. You need to know the length of your sheaths. Most of these are pretty standard, but they have to be long enough to get you up into the abdominal aorta. And there's some sheaths that are expandable, and there's some that aren't. And we have inline now, a sheath built into the TAVR, where you just put it in there and the sheath goes in and the TAVR then keeps going. So you never get any thicker than the actual TAVR device itself. There are some tricks about sheaths. We actually put a Gore, we like Gore dry seal for the most part, in a very torturous old lady, and it kinked because they're thin. So we pulled it out and put a Cook sheath in, which are thick. There's some minor things, but you'll learn 1 or 2 sheaths. It's like there are a zillion aortic valves out there. Nobody in this room uses every valve that's on the market. What you learn is you learn 3 or 4 that you like, and you're going to learn 3 or 4 sheaths that you like. Wires, you know, everybody gets confused about a wire. Do you want your high torque floppy, your BMW, your quick cross wire? You know, the cardiologist can make it sound like these are all magic things. They're not. There are 3 sizes we use: 014 for coronaries, 018 is in between, and 035 is what we use for TAVR. I use an 018 for my safety wire. Those wires come in different lengths. You need to know the length from the groin up to the heart. You know, we use little short wires to put in your sheath, but if you want to go all the way to the heart, you're going to have to get up to 180 to 230. And some of these wires we use are 300 centimeters, like exchange length wires. They come with straight tips and curved tips. The curved tips are more safe going in. The straight tips are used for things like crossing the valve. And they come in stiff and floppy. And there's a variety of stiff wires that can confuse you, but what will happen is you'll find 2 or 3 that you use over and over again. They're all made a little bit differently, and once you learn this and you learn the wires itself, again, like surgical instruments, you don't need to use every instrument out there. Find the wires that work for you. And you'll also learn there are a few other trick wires that you need every once in a while. Every once in a while you can't get across, and you'll get these hydrophilic wires and these quick cross catheters. That's not magic stuff. It seems like it is until you learn the language. We used to have to curve our wires to go in the ventricle because you don't want them straight, and we'd curve them ourselves, and it was kind of hard. But now they make pre-curved wires. So I tell all my residents, I remember the days when we curved our wires barefoot. You know, now you guys get these pre-curved wires. And it makes it really easy because they're manufactured that way. And then in the days when we curved them, if you put them in and had to take them out, you had to recurve them again. These hold their curve, and they're really easy to use. Catheters. There are all kinds of catheters. Again, this usually freaks out surgeons, but this is a Judkins left on the top, a Judkins right on the bottom. These are coronary catheters. I only put them out there because they come in different shapes. When we do TAVR, there's a limited number of catheters you need. We use a Lima catheter to cross over and do a safety wire. We use an AR1 to cross the valve. If that doesn't work, we use an AL to cross the valve. And then we use pigtails. One's a straight pigtail with markers, and one's an angle pigtail. Those are all the catheters I need to do basically 99% of the TAVRs. You do need to know the lengths, though, because, again, if you're going to get all the way up there, you're going to need something that's about 260 centimeters long. And if you're going to do an exchange, it needs to be longer than that. So these are pretty simple things. There are some techniques, crossing the valve. We get up there and we have to cross the valve, and first time a surgeon walks in, they see a cardiologist crossing the valve, they think there's something really magic. They're somehow lining it up and they know where the center is and they aim right. No, they're just taking the wire and they're poking. And they're moving it and they're poking around until they cross. It's the law of averages. If you poke it at enough time and you move it each time, eventually you'll hit that hole and you'll cross the valve. And then you get across. Now there are a couple tricks because sometimes your catheter don't want to follow after beyond it, and there are a couple tricks you have to learn. But again, it's not magic. Balloon aortic valvuloplasty, I remember watching them put these balloons in and blowing them up. I got, my God, how much do they blow up the balloon? This looks really hard. You know what they do? They put the balloon in, they get in, they pace, and they just push it as hard as they can. When the balloon fills up, it's filled. That's it. We can all learn that. It's pretty easy. And then implantation, all the valves have a slightly different implantation technique. But surgeons are really good at thinking in 3 dimensions. Surgeons are really good at doing technical things. There is not a surgeon in this room that cannot implant these valves. We were asked to actually do a little article for the Annals, Transcatheter Valve, How I Teach It. We'll show a little video. We can play that. If you guys can click on it back there and make it play. I did this with Ross Rule, one of my partners. So one of the things that we do is if you're going to do a TAVR with me, you have to show me you can do the measurements. You can't walk in and do it. You can't give it a radiology report. You have to take the CT, do the measurements, and show me you understand how to do the measurements and how those measurements relate to that valve. Now, you don't have to remember every valve. That's what we have charts for. We have charts on the wall. So if you're going to use an S3 or an Evolut, you look at it and say, this is what we're going to do. Everybody uses ultrasound. It's very simple to do. You know, it's set up for me every time. We use micropuncture technique. That way, if you miss, there's not much of a penalty to pay. We used to put all our pacers into the neck. Now we're starting to put them into the groin and pull them out again because all the pacemaker rate's kind of going down. We're going to go up. This is a Lima catheter, and we're going to go up with a glide wire, hydrophilic wire, and we're going to go across the bifurcation of the aorta, and we're going to go down the other side. And once we're down the other side, I'm going to take the glide wire out and put in an 018 Platinum Plus, just a steel core wire. It's a safety wire. I now have access to the other side if when I pull out my large sheath I get in trouble, and it's a target to look for on the large sheath. And since it's to a 6 French sheath, I now have a room for an 018 wire and a 5 French marker pig to go up through that. So I can do both of those. So now we've punctured the vessel on the large sheath size. Again, this is all micropuncture technique. And once we get access to the other side, we give heparin right away. My cardiologist used to hate giving heparin because they were worried about bleeding. I tell them, I don't worry about bleeding, I worry about clotting. I can fix bleeding. This is a ProGlide. We put it into it squirts. You can see it squirting there, and then we pull it back till the squirt goes away. We deploy the needles. We cut the thread. This little first thing is a foot that brought it. Now we let the foot down. We take it out, and we're going to grab our threads, and we just take a little piece of sterile tape and tape them up. And the keys are when you go in, you got to see a good squirt. So we're going to go in again with the next one. We get in, we take the wire out. Now watch the little thing on the top squirt. You see it squirting? Now we know we're in the vessel. We're going to pull the foot back. And when we pull the foot back, now we pull it to it says, now it has to go away. When it goes away, that means I've sealed it and I can fire it. And where I see people get into trouble is they just try to use this without understanding the concept of when it's in the right place. And at my place, I insist the surgeons be able to do every single part of this. I mean, the surgeons are not going to be standing in the corner cutting down if you get in trouble. In fact, the other day, both my staff cardiologists were out, and I was in there with a fellow, and we just started the case, and my guys came in after their STEMI as we were almost done. This is a 10 French dilator we put in. Remember, as a surgeon, you have to remember that when you're doing this, you got to be looking at the monitor. Eyes on the prize is for cardiologists, and for TAVR implanters, it's the monitor. For surgeons, it's the patient. So you got to remember, you're not interested in what's happening right there at the groin, but you're interested in what's happening in the wall. This is a stiff wire. It's called an Amplat Super Stiff Wire. And we put it under direct vision up to the aorta. We pull out the 10 French, and this is an 18 Gore dry seal. And we're just wiggling it up. We put a little curve on the end, And you can watch it and you can feel it. You don't usually get in trouble going up. It's when you come out that you get into trouble. And then we tie everything, we suture everything down so nothing moves, and we then do a checklist. We have a checklist to make sure we're ready. Now we put a 5 French marker pig up, and we shot that implant arteriogram. We want to make sure that our coronary cusps are well lined up. This is the famous Dr. Kleiman, my partner, and Ankar Kalra, my fellow, while I'm filming them. So Ankar's now going up with a AO1 catheter through the large sheath and a J-tip wire. J-tip because it's safe. Once he gets up there, now see, he makes sure it bleeds, make sure the air comes out. Don't, give it a little time for the air to come out. You don't want to shove air back up in there. And now he's got his straight wire. Now we filmed it like the straight wire just went right across, but there are times it takes considerable time to get across. Now we hook up and do hemodynamics. And the interesting thing about this is you do your hemodynamics, and I ask my fellows, well, what do you look at? And they always tell me about the difference between the peak pressures. We don't care about the peak pressures. We know they have stoves. What you want to know is the difference between the LV EDP and diastole, because that difference needs to be that big or bigger at the end. Because if it gets less, it means you've created an AI. So we know they have AS. Don't worry about it. Look at the end of diastole and look at the LV EDP. And at that heart rate, when you finish, it needs to be less. If it is, then you haven't created significant AI, because what the heart sees is hemodynamics. So now they're going up with a balloon. We tend to use true balloons. There are some caveats to balloons. The Z-meds don't go up to their nominal diameter. True balloons do. They're Kevlar. They're very struck. So we rapidly pace. We blow up the balloon. Again, notice that the delicate technique of just pushing the balloon as far as you can go, and you're done, and then letting it back down. And then you turn your pacer off, and we're going to then take the balloon out. Now we're going up. This is an Evolute. This is an inline sheath. Typically, we just use a regular sheath. We're not big fans of inline sheath, but that's just how we are. You can do a smaller vessel with an inline sheath. So we've got it in position. Now we're deploying it by turning it. These are self-expanding, so you go very slow. We've lined up the ring. You can see the pigtail. You can see the non-coronary cusp. We base everything off the non-coronary cusp. This is not obstructive except for a very, very short period. And then we go to 2/3, we look at it. Now here we've actually released it. And you can see the valve in place. There's basically no gradient. There's no PVL. I'm a little out of sequence here, but then we recapture this and we take it out, and we're going to repeat the hemodynamics. With this particular self-expanding valve, there is never a gradient on hemodynamics, never. If there is, something's wrong. The valve's not expanded. You got to go back and find it, because these always lie on top of each other. Now, sometimes in valve and valve, that's different. They're a little constrained, but even in some valve and valves, the results tend to be pretty good. So this is the hemodynamics. You can see there's literally no gradient. The difference between the end diastole and LVEDP is no less than it was before. It's exactly the same, which makes sense because there was no real AI before. We're going to do a final arteriogram just to look at depth and make sure, and that looks okay. Now we're going to take the sheath out. And as we take the sheath out, put your dilator back in. The reason to put the dilator back in is as you're pulling up on your ProGlides, they'll follow the dilator down. Instead of just getting to the end and clomping down, they go down gradually. So that looks good. We're going to pull our wire out. Those are our ProGlides down. We give protamine at this point. And then we always do an arteriogram at the end to make sure that there's no bleeding and there's no obstruction at that site. Now, currently, we use 4 different valves in this hospital. There used to be 5. We had direct flow, but direct flow just went bankrupt. Sapien S3 we use as a commercial valve. The Evolute R we use as a commercial valve. We just started yesterday putting in our first Evolute Pros. Evolute Pro is the new Evolute R that has a wrap around it. It's kind of like the Sapien skirt, but I can't call it a skirt because there's intellectual property, so it has to be a wrap. Otherwise, I'll get in trouble. And that was presented at ACC, and with the Evolute Pro, 3/4 had no or trace PVL, 1/4 had mild, nobody had above mild. That's starting to sound a lot like a surgical valve. And so we did our first 2 commercial Pros here. We were part of the Pro trial. We did our first 2 commercial Pros here yesterday. Lotus, I was part of the Reprise 3. Lotus is an interesting, the Sapien's a balloon expandable, Evolute R is a self-expanding. Lotus is a mechanically expandable valve made out of nitinol. So it expands to its size. There's a buckle and a post and a wire, and as you turn a handle, they bring these together until they lock like a seatbelt. And as you shorten something, what happens to it? It widens out. So it's very much like having an S3 that you can dial out slowly, and it's never obstructive. You can go out as slow as you want. And the interesting thing about this valve, the Evolute R is recapturable when it's 3/4 deployed, but then you have to let go of it. The Evolute, you can deploy 100%. I mean, the Lotus, you can deploy 100% and look at it. If you like it, you let it go. If you don't like it, you can unlock it, move it, put a new valve in. But you always know exactly what you're going to get when you let go of it. Now, this is the Reprise 3 is going to be presented at EuroPCR by my co-PI, Ted Feltman. The Lotus valve is actually on a pause now. They went to a new delivery system called Edge with depth guard, which is going to keep us from going too low. And changing delivery system, there were some manufacturing issues with the pins that hold it. And we had 1 or 2 pins that came out early. We actually had one here. We recaptured the valve and just had to reload another valve. Once they're in and locked, that issue is not a problem. But Boston decided they were just going to hold this valve until they figured that out. A little disappointing because I'm going to be the surgical PI on Reprise 4, which is intermediate risk, with Greg's old partner, Raj Makkar. And we were excited about getting started up, but we're going to be a little delayed for that. And then Portico. Greg is the surgical PI on Portico. We're enrolling in Portico right now. Portico is the St. Jude self-expanding valve. It is a little different than Evolute. It is intra-annular, but you see the larger sizes of the diamonds. That was designed to help seal against the calcium, let the calcium get in against the pericardium and decrease the paravalvular leak rate. Sapien and Evolute are now commercially available. I suspect Lotus will be commercially available later this year, and then when we finish the Portico trial, hopefully the results from the Portico trial will then make it commercially available, so we'll have 4 valves that are available to us. So thank you very much. Learn TAVR if you want to keep operating. You got to have something to do.